that was coming up. Coming up.
Niligundua akiwa 2.5 ndo nilijua ako na shida ya hearing, na nilijua kati anacheza ukimuita ha respond.
From signs to speech, baby Precious begins her journey to hearing and speech.
So it's a multifactorial. We have the radiologist or the radiographers who the CT scan and the MRIs. We have the vaccination that is part of the requirement for patients who are undergoing cochlear implantation.
Cochlear implant opens new world for baby Precious, and on good practice, signs and symptoms of deafness in children. Now let's look at our first segment, where every child responds to sound, except when sound does not exist. At just 2 years old, Precious showed no reaction to her mother's voice, raising concerns that would later confirm a lifelong altering diagnosis. Precious was deaf. Her mother, Anne, realized she had to shout to get her daughter's attention. That followed a lifelong journey marked by fear, but then breakthrough that would change everything. Here is her story. At just 2 years old, Precious' mother, Anne Wamboy, began noticing something unusual about her firstborn daughter. No matter how softly she called her name, Precious wouldn't respond. Anne had to shout for her child to turn around. Medical assessments later confirmed Anne's fears. Precious could not hear.
Niligundua akiwa 2.5 ndo nilijua ako na shida ya hearing, na nilijua kati anacheza ukimuita ha respond, either you shout. Ukishout ndiye atasikia. Ndo nilinotice ako na shida ya kusikia.
To help her daughter develop speech, Precious was fitted with hearing aids. They offered some support, but communication remained difficult, forcing Precious to rely on sign language and lip reading.
Changamoto yangu ilikuwa kitu ya kwanza, singemulilisa ende akacheze na watoto wengine. Maybe akai mahali namuona, lakini kwenda uko mbali hapana. Niakwe mahali niko karibu na yeye.
Hope came when Precious was selected for a cochlear implant procedure, an opportunity Anne describes as God sent. Precious was among 50 children who underwent cochlear implant surgery at the Kenyatta National Hospital, marking a major turning point in her life.
Alifanywa surgery on November, ikakuwa activated January. So amekuwa nayo from January up to now.
4 weeks later, today became a milestone. It's switch on day, the moment doctors activate the implant to determine whether it's working.
Microphone ziko kwa hii, ziko mbili. Hii ni moja.
At the Kenyatta National Hospital, audiologist Dr. Nancy Kemunto patiently explains how the device functions, guiding the family through what to expect. As the device is switched on, something remarkable happens. From the expression on Precious' face, it's clear she can hear the beeping sounds. It is a moment filled with emotion, relief, and renewed hope for other kids too. But the journey is far from over. While the implant allows Precious and the other kids to hear sound, they must now learn how to interpret them. And that's where speech therapy comes in.
Akona tofauti, kuna some words hakuwa anatamka. Na saa hizi at least anaongea. Amekuwa na improvements ya words, amekuwa na courage pia ya kuongea juu anasikia vile tunasema. So tayari anatamani kuongea kama sisi.
For Anne, the future now feels brighter. She's also using her experience to encourage other mothers. Hearing plays a critical role in a child's speech, learning, and social development. When hearing loss goes unnoticed, it can delay communication skills and affect a child's safety and confidence. Early detection is key, as timely medical intervention and therapy can significantly improve outcomes. And so in good practice, we look at what parents and caregivers should look out for. Early signs and symptoms of deafness in children from 0 to 12 months can include No reaction to loud sounds, doesn't turn to voices or familiar sounds, no response to parents' voice by 6 months, and limited or no babbling. By the time they turn 1 to 3 years, some of the signs you may spot are the child doesn't respond when called by name, delayed or unclear speech, relies on gestures instead of words, watches faces to understand communication, and probably turns the TV or phone volume very high. For preschoolers, difficulty following instructions, frequent asks like what, or repeats requests, poor pronunciation or limited vocabulary, appear inattentive or withdrawn in class, academic struggles despite normal intelligence. Safety and behavioral signs can include the child doesn't respond to alarms or hooting, startles easily when touched from behind, seems isolated, unusually quiet, or frustrated. And so some of the steps that you can take for early diagnosis include trust your instincts, seek assessment early, screen hearing early if speech delay is noticed, attend regular child wellness checkups, follow through with hearing aids, implants, and therapy. 1 in 1,000 children in Kenya is born deaf, a reality that can shape a child's entire future. At the Kenyatta National Hospital, a landmark program involving 50 cochlear implant surgeries is offering a new beginning. Audiologist Isaac Wahome explains how the life-changing device works and what families should expect.
If you look at causes of hearing loss, in 90% of the cases is usually idiopathic. We don't know what causes or what can cause hearing loss. But in 10%, there are identifiable factors that we know that can cause hearing loss. And one of them is genetic. Like you have said, in genetics is what causes congenital hearing loss. And then we have what we call acquired hearing loss, either due to infection, very common infection in newborn or in children. The torches type of infections, of course, infections like meningitis, that are preventable, and of course ear infections, the commonest being otitis media, that can result to hearing impairment. Apart from infection, we have other causes, especially in older people, like noise-induced hearing loss. We have age-related type of hearing loss that basically can occur, especially from 50 years and above, what we refer in medical term as presbycusis. Of course, these are some of the identifiable causes of hearing loss that we know. There are some that actually people just develop hearing loss with no identifiable cause, but infection is one of the, of course, high on the list, from newborn all the way. There are people who develop sudden type of hearing loss from infections of just viral infection, bacterial infection, and the commonest bacterial infection being meningitis. And medication again can cause hearing loss. There are some medicine as simple as aspirin that can cause hearing loss. Of course, trauma is another cause of hearing loss, and we have seen very commonly for people who have been involved with road traffic accident, assaults, especially if they have some fracture of the temporal bone, or in simple terms, we call it fracture around the head region, can cause hearing loss. So in a nutshell, these are some of the causes of hearing loss. And like you had talked about, congenital or genetics related type of hearing loss is also a cause of hearing loss.
Okay. So let's talk about the cochlear implant program that you had, and about 50 children were, eligible and at least benefited from these cochlear implants. I mean, it's a very expensive affair that's no ordinary Kenyan. I mean, it runs into millions of shillings just getting one cochlear implant. But just take us through, what was the process of screening for these children?
So I think even before you talk about cochlear implant, maybe some people will ask what interventions are there.
Yeah.
Of course, we have different types of interventions, and one of them is people who experience hearing loss. One of them, they basically see an ENT or an audiologist for a hearing assessment. And then this hearing assessment report, depending on the age group, for very young children, usually from 5 years and below, and sometimes we go even low as 3.5 years. We usually do what we call brainstem evoked response audiometry, or BERA, or ASSR, and sometimes just doing a basic screening with autoacoustic emission to find out, number one, whether they have hearing loss, number two, so that we can be able to get them and know at what level of hearing loss that they have. Now, depending on the type of hearing loss, we can do further assessment by doing what we call a tympanometry, again, so that we can classify the type, whether it's a conductive hearing loss, mixed hearing loss, or a sensorineural type of hearing loss. For conductive type of hearing loss, for sure, one of the remedies include things like medication and surgical intervention by either putting grommet or repair of tympanic membrane for those who have perforated tympanic membrane. And mixed, sometimes it could be a mixture of either medication and sometimes just surgical intervention. For surgical intervention, again, you can have advanced intervention that includes repair of the tympanic membrane, or the middle ear ossicle reconstruction, and those kind of advanced type of surgical intervention. When we know then it is not a conductive type of hearing loss, then we result into doing either amplification. And amplification can be hearing aid amplification or cochlear implant amplification. For hearing aid, there's a limit in terms of the level, because we have patients who can have hearing loss from as low as mild hearing loss up to severe type of a hearing loss. And then for patients who have sort of like severe hearing loss and they're not benefiting from a hearing aid, these are very good candidates for cochlear implant. But for sure, there's a criteria that we choose for patients who will benefit from cochlear implantation. And one of the criteria is patients who have, for example, severe to profound type of a hearing loss, or they have not benefited from a hearing aid that they were fitted before. If they do not want hearing aid, if they do not want cochlear implants, then they fall into a category of alternative intervention that includes sign language intervention, and of course for children that they require to go into special schools. Now, back to your question in terms of the process of cochlear implant. The process of cochlear implant is very elaborate. That requires, one of them is a multi-sectoral, or require a team approach. And our team approach includes the ENT surgeons, the speech therapists, the audiologists, the counseling psychologists, of course, the nursing team. So it's a multifactorial assessment approach, where the audiological assessment includes doing things like a hearing assessment to determine, number one, if there's hearing loss, number two, what kind of or level of hearing loss, so that they fit now into candidacy. And then the surgical team will look into how the temporal bone is. Is it first of all there? Is it something that is operable and so on, so that they are able to put an implant? And then, of course, into the mental aspect, where the counseling psychologist will come in and talk with the patient so that they are prepared into the surgical procedure. And the nursing team in terms of preparing, and of course, what you have talked about, financial aspect that involves cochlear implantation, and so on. So it's a multifactorial. We have the radiologist or the radiographers who the CT scan and the MRIs. We have the vaccination that is part of the requirement. for patients who are undergoing cochlear implantation. So it's a whole package that we take in consideration, so that we can be able to say for sure you are a candidate of cochlear implantation. And once a candidate has been chosen by this team, then they go now into the process of starting to be implanted.
So the process, like you've already put it, you have to know exactly what level. Is it profound? Is it mild? Is it moderate? And all that. And then the children went through the cochlear implants already. So I know we'll be getting to what the process is. But just for someone listening and they think like, oh, the minute the child goes through or someone goes for a cochlear implant, they immediately, I mean, not immediately, but after healing, maybe after a month or so, they should be able to speak. They should be able to just now be like everybody else, hearing and all that. But that is different. As an audiologist, I remember visiting your office on the switch on day. How important is that particular day? Because after the surgery, they stay for about, is it about 4 weeks before they can actually come back? Because it is not on, the implant is not on at that time after the surgery. Maybe you could explain that to us also.
So basically, like you have said, it's a process. I mean, like it's an intervention that requires a lot of consideration, a lot of planning. So we have the pre-cochlear implantation planning stage. And then we have now the second stage, which is the surgical intervention stage. And during surgical is where they come in the hospital, they are admitted, there are a few blood work that are usually done to be sure that, like just basic things like their hemoglobin is okay, their creatinine is okay, for the sake of safety in terms of anesthesia and so on, because the procedure has to be done under sedation. It's a procedure that basically takes around, on approximate around 2 hours, I would say. And so that is the surgical intervention where now the implant is usually surgically implanted into the cochlea. And after surgical implantation of the cochlea itself, they're usually sent home, some of them with medication and follow-up, just to make sure that the wound heals after surgery. And then after that, now they have to come back now. They have finished now the surgical phase where healing has to take place, and they come now into the audiological stage now, and the audiological stage involves, number one, what you have referred as switch on, and switch on now involves having a processor, the external processor. Remember, during surgical, there's an internal implant that is put, and during switch on now is where we are merging an external processor with the internal implant, and then making sure that they are able to connect and open up now for what we call mapping. So mapping now, we start putting a few programs and we put them in multi-stage. We start off by number one, making sure that the sound is not as we expect, because it's a process. So from the audiological aspect, they start what we call now a rehabilitative process. And the rehabilitative process, one of the key things that I had said or I had mentioned before is that the brain adapts to sound, and children will react differently depending on how we introduce sound. So most of the time when we start during switch on is we do not want to stimulate or increase a sound to the optimum level, that because sometimes when we want to optimize or when we want to reach a certain level, it might be very uncomfortable being the first time. So we start off by doing step-by-step increasing or step-by-step approach of introducing sound to the brain. Remember, even for these children when they are born, they do not develop speech immediately. It takes time. They have to get external stimulation of sound They have to get used to that sound. They have to familiarize themselves with sound. And then after that, they start sort of having some verbal expression with speech and language.
Yes.
So switch on number one is we want to match the two, the internal implant with the external processor. And then during the first time we give them or we introduce them to sound. And then after that, they have to come for several stages or they have to come several times so that we increase their volume step by step. I will call it volume, but just increasing step by step or slowly until we reach an optimal sound. Most of these children that we have already done switch on and we have already done the first mapping, we are on the second mapping, they have already started, liking. First of all, they like their implants. Most of them, they really love their implants. Number two, because sound is a motivation for these children. They have never heard before, but once they start getting some sounds around them, like banging doors, opening doors, things falling, and they're able to know the environmental sound, they get excited by that and they love that. After that, now, in terms of speech, we start increasing them gradually. And during that process, we gradually start introducing them to the speech therapist. And then the speech therapist, they will teach them how to verbalize. They'll teach them listening skills because one, we want them to develop as much as possible listening skills so that they are able to hear from their ears and then their brain are able to process that sound. And then from the processing, they are able now to give or respond to commands that they're given.
Well, and on that note, we've come to the end of the program. Thank you as always for your time and your company. My name is Maria Mbo, and on behalf of everyone who made this program possible, the audiologist Isaac Wahome, and of course, Anne just giving us the story and the journey of her daughter with deafness. We do really appreciate their time. And so on behalf of everyone, we hope to see you again